Well, our first clinical speaker today is someone that I met 20 years ago when I first moved to Colorado, and she interviewed me for the Geriatrics Fellowship Program. She was one of those friendly faces who I was totally scared of because she's a prominent geriatrician and researcher and has dedicated her life to geriatric medicine as well as post-acute long-term care. So today we have the pleasure of inviting Dr. Cari Levy to give our first talk, and she is the division head of geriatric medicine at University of Colorado. Thank you, Dr. Levy.
Great. Well, thank you so much for having us here. I know we have a whirlwind of talks today, and so this will be a whirlwind, but I'm looking forward to talking about hypertension. I think the slides will come up. Hypertension in older adults. Oh, I get to do it. Outstanding. All right, here we go. I get to advance the slides. Perfect. Okay, no problem. So we're going to talk about hypertension guidelines. There's a lot that has happened in the last year or so, and so the hope is to blend all of the trials that you're aware of and the studies you're aware of and integrate the new information as best we can so that we can arrive at a nice target goal for our older adults. And we'll frame a lot of this in the nursing home population so that it's relevant to the type of work that we all do. So our objectives today are to talk about recent randomized controlled trial evidence about blood pressure control in older adults, to look at some of the key differences between studies that we all have practiced based on, but that might lend themselves to new interpretation with some randomized controlled trial data. And then importantly, I think a lot of what we're going to talk about is the art and adventure of geriatrics. So we don't just have a target for a person at a certain age. We really have an art and an adventure to all of this. So we're going to talk about frailty, which will lend itself, I think, to our next talk by Jennifer Stevens-Lapsley. And then some of the the evidence-based tools that we have available to us. So let's go ahead and get started. So the clinical dilemma that we're facing is that many of the studies we have excluded frail patients and the population that we care for. We know that the guidelines are inconsistent, and only 2 of the 34 specifically have targets related to frail patients. Observational data, many of us have seen and made us worried about intensive control in frail older folks. And now we've got some new trial data just this year within the last few months that might challenge some of our assumptions. So my hope is to bring it all together and allow you to walk away with some confidence in how you're approaching your older patients. So here's the problem, is that we have lots of different guidelines and they all say something different. So we have some European guidelines that say for people over 80, the target should be 150 or lower. For the ACC, the American College of Cardiology and American Heart Association in 2017, they said less than 130. You got to get them less than 130, regardless of age. And then more recent guidelines from the ACC and AHA in 2025 said, okay, let's go lower to 130 with individualization as best we can. And then ACP and family practice, if you're over 60, 150 is good. Okay, so these are all currently available guidelines, and they all say very, very different things. So our hope is to now put some context to that. So SPRINT, I think many of you are familiar with the SPRINT study. So this was over 5,000 patients who were over 65. And an important interpretation with SPRINT is, what do we care most about? Do we care most about preventing a cardiovascular event, or do we care most about really balancing harms and potential benefit? So if we have somebody that says, I want to have my cardiovascular events prevented, and if I feel a little poorly, if I fall, that's okay. I want you to do whatever you can to prevent an event. Then we know from SPRINT that 100% of people improved or reduced their risk of cardiovascular events if we controlled their blood pressure to the targets that were in SPRINT. If we do a little bit of balancing of harms and benefits, then there's also benefit for 85% of people, and greater benefit in those who are frail because, of course, they are higher risk of events going forward. So how do we put all this together? Basically, I keep pushing the wrong thing. There we go. That even when we account for harms in the SPRINT study, most people, most frail people, will benefit from intensive control of blood pressure when the cardiovascular risk is high. So this will start bringing in some themes that will hopefully bring together by the end of this, which is, are these individuals at high risk? Is this patient before you at high risk? Have they had a stroke? They've got diabetes. They have a lot of risk for a cardiovascular event. Then that's someone we want to try to get to a lower blood pressure because they have a lot of room to benefit from that control. So we'll start with that tenet. In 2023, there was a cohort study that had millions of patients. So these were the 3.8 million people on hypertensive management. And I know we all worry about falls, right? This is a big concern in treating blood pressure. And in this population, there were 6 events per 10,000 patient years in the overall population. But when we looked at people over 80, there were many more events, many more falls, 61 per 10,000 patient years. And if we had if we looked at the severely frail population, it was 84 events. So a 14-fold increase. And all of this is very upsetting, right? We don't want people to fall. We don't want them to get injured. And other events included hypotension, a higher risk of that with intensive control, syncope, also worrisome, and then acute injury. So let's keep all of this in mind. We worry about falls, we worry about syncope, we worry about hypotension and acute kidney injury. So continue worrying about that. It's important to keep that in mind because we deal with a really frail population. And we know that the absolute risks are higher in frail older patients. So you see an age range here of 80 to 89, and we also start to begin to introduce this concept of frailty. And this is an important piece. Age is not helpful. We all know that. You can have a very robust 80-year-old and you can have a very frail 80-year-old. And most of the studies done to date have been based on age. And one of the big changes in the last few years is let's talk about frailty rather than age. So that's one of our big messages today. And speaking of frail folks, this was a very important study in 2025 that I'm sure many of you saw that had to do with deprescribing, and it was done in nursing homes. There's so rarely a study that's done in a nursing home, right? But this was 1,000 patients. It was done in France, and they had frail nursing home residents who were over the age of 80. So, hey, we're starting to get more towards our population. We've got frail folks, we've got folks in a nursing home. And what they were looking at here is, could we deprescribe, right? We have a lot of folks who are on many, many meds, and so what if we deprescribe, and is that safe? And in this group, frail nursing home population, mortality was basically identical, regardless of if you were in the keep all the meds group or the let's take some meds away group. And the message that came out of this is that deprescribing is probably good to think about in someone who has a lot of medications and who we want to avoid polypharmacy. And it did not change mortality. So keep that in mind as we think about all these different factors. So some of you might be thinking, hey, wasn't there also a French trial where they looked at nursing home residents and it was really scary because a lot of them did poorly when their blood pressure was low? And your memory is serving you well. That was the PALTmed study in 2015. And I think many of us thought, okay, this is what we experience each day. We have nursing home residents over 80. If we really try to drive their blood pressure down, it causes problems. And in this case, it showed a higher incidence of mortality the lower the blood pressure. An important piece is that PALTmed was an observational study. They did not randomize people to lower blood pressure versus usual care. And so always have a lot of doubt in your mind when you're looking at an observational study, because we're just viewing people in the community as they are, as opposed to making sure that they're equal populations. And so we're going to compare that to the retreat frail. I know we're talking about a lot of studies, but the general idea here is we've got older people, we've got frail people, and in retreat frail, it was a randomized controlled trial. It was a similar population. And the mortality in that group, really there was no difference in mortality in terms of the deprescribing. And so we have two different trials here showing somewhat different things, and the key is that observational studies view them with concern because they are not a randomized control trial. Retreat Frail, I do think, was very well done study, and deprescribing is a reasonable thing to think about when you've got a nursing home resident who has too many meds. And incidentally, in that study, the blood pressure only increased by 4 millimeters of mercury, so it wasn't a dramatic change when you started deprescribing. Okay, so we've started introducing this idea of frailty rather than age, and so if we now pool a couple of different studies that included frailty, what do we find? And essentially what we find is that frail folks should probably be somewhere between 110 and 140, and the range, upper or lower range, probably depends on how frail they are. So a little bit higher for frail folks, also taking into account their risk for cardiovascular events. And then for non-frail patients, regardless of how old they are, if they're 90, if they're 95, and they have a high risk of cardiovascular events, we can get them low. We should probably be working to get their blood pressure down below 130. So frail patients, keep them somewhere between 110 and 140 and use your judgment, which we'll get into more in a minute. Non-frail patients, try to drive their blood pressure low. They can tolerate it, at least based on these trials, and they will have lower mortality and cardiovascular events. And J-shaped curves are also key with all of these different studies, in that if you're very low or you're very high, then you're in trouble. So we don't want to drive it too low. We don't want to drive it below 110. We also don't want it up in the 160s. That's where people get into trouble. And that frailty is the key. Age is not helpful. Frailty is helpful. Then the most recent one, and this is the last trial I'll mention, which is the Esprit trial. And this was a 2026 study. It was looking at 11,000 patients who were at high cardiovascular risk. So these are individuals who have a lot of potential to benefit from good blood pressure control. And really cool, and this is exciting for us, that studies are now really trying to include frail folks. So we had 38% in this trial who were non-frail, 46% who were moderately frail, and 14.5% who were severely frail. And in this study, what they did was try to compare intensive management, less than 120, to standard management, which was around 140. And what they found was that the cardiovascular benefits were consistent across all of these populations. If you were non-frail or you were severely frail, you achieved benefit if your blood pressure was intensively managed. They didn't find a difference in falls. They didn't find a difference in other adverse effects except for kidney function. So there was increased kidney impairment with the intensive group if you were severely frail. The other groups did okay. So the conclusion here is that regardless of how frail someone is, we probably need to be very intentional about getting their blood pressure down if they are at high cardiovascular risk, which many of our patients are. And the key here is that the frailty status was important. The individuals who were non-frail, pretty easy to get them to target. The moderately frail folks we need to be gentle with, and it took a little longer to get them to target. And then for the severely frail folks, we can get them there, and probably should, again, if they're at very high risk of cardiovascular events, but we need to be slow, and we need to take our time, probably months, getting them there. And the message overall with Esprit is that we need to individualize our therapies, not based on age, but based on frailty, and if someone's at high risk, try to drive their blood pressure as low as we can, being mindful, of course, of all the things we worry about with falls and syncope and those types of things. But in this study, they did not see that. Now, one important caveat is this is a study. People are managed very carefully. You have humans going in and measuring their blood pressure. You have humans looking at their blood pressures carefully and delicately adjusting things. In a large population of folks who didn't enroll in a study, things are much less controlled, right? So this applies to a study population, not necessarily the folks that we're taking care of who are, in a much less controlled environment. So I mentioned frailty. So how can we look at frailty and how should we integrate this into our practice. So there's 3 major ones that I'll talk about here, and the one that I think you can use as a practical tool is the clinical frailty scale, the one in the middle there. So I bring up the Rockwood Frailty Index just because it was used in Sprint and Accord and Esprit, so all of those trials used it. It's very much a researchy kind of thing. It's got 31 items, and then that's how they categorized people as non-frail, frail, or severely frail. The clinical frailty scale is pretty useful. We use it a lot in our practice, and I encourage you to do the same. And then a lot of the tests will also use a physical performance test like the short physical performance battery. So I'll show you what that is, just so you're familiar with it, and some of the elements you may be able to incorporate from a practical standpoint. So you may have seen this. This is the clinical frailty scale, and it goes from 1 to 9. 1 is very fit. 4 is where we get into more of the, a little bit of not dependence on others, but needing some assistance and slowing down, essentially. 5 is mildly frail. This individual has some evidence of slowing down. They have more need for their IADLs. And then when we get to 6, this is probably the population we're most often seeing, which is someone who needs help with all of their outside activities, keeping house, that type of thing, and help with bathing. And then nursing home is typically the severely frail, so completely dependent for personal care. Important to keep this in mind as we're talking about how to deal with blood pressure, because most often we're dealing with 7 through 9. Unless you're working in a community setting, that's probably what we're speaking of. So keeping a close eye on the frailty piece. Just a quick thing about the short physical performance battery. This involves a balance test where you stand and then stand basically like a normal stance, and then you have a semi-tandem, and then you have a tandem stance. They measure your gait speed, and then 5 chair to stands. And there's, of course, scores associated with how well you perform in those areas, and that's how many of these studies are also done. So just to give you a sense of what that is. I will say gait speed we use a lot at the university. We have a gait speed measurement tool in the clinic, so if your patient or your loved ones are coming to that clinic, they will have their gait speed measured. If it's below a certain threshold, they will be sent for physical therapy. And we know that, and maybe we'll hear about it today, that gait speed is associated with longevity. So faster you walk, longer you live, slower you walk, less long you will live. This is just some more detail about that. And so how do we put all this together? We know age is probably not the way to do this anymore. We know that people probably tolerate a lower blood pressure than we think in a very controlled study setting. And we know we have to be cautious and take the frailty piece into account. So let's go through just a couple of cases here to put this all together. This is a frail male who is at high risk for cardiovascular events. So we want to try to keep things lower for him. He's 85 and he has severe frailty. So this is the art and adventure of geriatrics. We've got a reason to keep his, to intensively manage his blood pressure, but he's also severely frail. So where would our target be? Probably in the 130 range, 130 to 140 range. And if we could drive it a little lower without having side effects, we can certainly try to do that because he is at such high risk of a cardiovascular event. The key is to titrate slowly, keep a close eye on him, measure his kidney function so we're not getting into trouble there, and we can take our time in doing this because it does take longer to do it well. So that's our first scenario. The second one is a frail female who has already a low blood pressure and she's on many medications. And you can guess where we're going to go with this. So she probably needs some deprescribing. And I think the trial from this year would show us that we can do that safely. Keep a close eye on her, and she doesn't have a lot of cardiovascular risk factors, so this is safe. So we can deprescribe, not worry about a mortality problem with that, and then if she has adverse effects, of course, another good reason to deprescribe. We've got here now a person, just to include that that clinical frailty scale. So she's 85, and she's a 4 to 5. And if you remember from our scale, that's somebody who has a little bit of slowing down, but is otherwise managing in the community. And here we will individualize, of course, and we'd have a target of less than 140 and ideally less than 130, but she's not at high cardiovascular risk, so I think we could live in the 130 to 140 range with her. So here's the overall approach, bringing it all together, is to assess frailty. You can use that clinical frailty scale, 1 to 9. Our folks are often the 7 to 9 group. You could measure gait speed. We're hoping to develop a gait speed measurement tool that you all could easily access and use in your practice. And then assess cardiovascular risk. If it's high, try to drive that blood pressure as low as you can. If they have a limited life expectancy, perhaps a little less intensive there. And then you can think through your individual targets. So if they are at high cardiovascular risk and they're frail, we probably have a 130 to 140 goal. If they already have low blood pressure, try to deprescribe. If they have severe frailty and a low cardiovascular risk, like we saw in some of our cases, you may be able to tolerate a 140 to 150 without running into trouble. The key, of course, with everything in geriatrics is start low, go slow, but eventually get there. And I think the message from these most recent studies is that we probably need to be a little bit more aggressive in our folks with very high cardiovascular risk. And be gentle, because we know that these are delicate folks. So when do we have red flags? Of course, when there's recurrent falls or syncope, symptomatic hypotension, renal dysfunction, I'm not sure why all that got cut off, and then electrolyte abnormalities. And then as people decline, going back and readjusting the goals and the targets. And we'll just finish with one last example. This is Nora, and she's 87. She's a nursing home resident. She's moderately frail on that score. She's a 6. She uses a walker. She has very high cardiovascular risk. She's had a prior stroke, diabetes, stage 3 kidney disease, and her blood pressure is at 145/75. She's currently on lisinopril and amlodipine. So what should we do with her? I think in the past you might have said, oh, she's a moderately frail person, and I worry about her kidneys, and should I drive it lower to protect her kidneys, or am I going to hurt her from driving her blood pressure lower? And based on all the trial evidence we have right now, we should work harder for Nora to get her blood pressure down. She's at very high cardiovascular risk, and so in her case, she's above target. We can try to drive that blood pressure ideally to somewhere around 130. And so increasing her amlodipine to 10 is a very reasonable thing to do. And importantly, checking her renal function in a couple of weeks to make sure that has not declined. Doing blood pressure checks often. And then if you've got a pharmacist available to help you, fantastic. And then always fall prevention if we can with some physical therapy. And then time. We can take time to get to target. So 2 to 3 months it may take. And what are we basing this on? We're basing this on a SPRE, which supports intensive control in severely frail folks. And again, I'll just make the caveat that a SPRE was a study. We had really, really careful monitoring of these folks. The real world is less controlled than that, and so it's always a balance, the art and adventure of geriatrics. So just to wrap up, our key takeaways are that our old paradigm where we're worried about intensive control in our frail older adults is shifting to trying to probably be more aggressive, and intensive management is favored. We certainly aren't going to use age-based targets going forward. We're going to use frailty. We know that intensive control from the ESPRIT trial in those with severe frailty and high cardiovascular risk is important. It's important to manage with intensive control, balancing with safety, of course, always. And then we can deprescribe safely without worrying mortality will increase in folks who were worried about polypharmacy. And then frailty, really using that rather than age. So individualizing our approach, taking into account cardiovascular risk, life expectancy, and being a bit more aggressive than we probably have been comfortable with in the past in terms of intensive control. Always monitoring for adverse events like falls, kidney function, and syncope. So thank you very much, and I hope that's a lot of trials, but hopefully all that crystallizes. think of frailty, probably we need to be a little bit more aggressive, but all of these studies were done in very controlled settings, and we live in the real world. So that's where you get to use your judgment, and that's the art and adventure of geriatrics. So thank you so much, and have a great day.